Thank you for the introduction, Xing Xing. I always love it when people say, I'm now going to introduce somebody who needs no introduction. So I'm a plastic surgeon in Leeds. I've looked after children's hand surgery, which has been my real first love and passion in hand surgery since well before I was a surgeon, interestingly. And the reason for that, as Xing Xing alludes to, is that I was a child patient myself. And I guess it was at an age when I began to understand that a lot of what was done to me didn't have my endorsement, my assent, and that there were some things that were frankly driven by technology or enthusiasm rather than caring for me. I want to get a lot, I'm going to make this a very personal talk, if I may, and I'm going to ramble through quite a few of my own prejudices and beliefs. So I'm not teaching you something other than what I think. I'm not saying my way is the right way, but I think it's a way you can look at and discuss. The first little bug in my life is that I really don't like the phrase pediatric. Why do we use a Greek word when we mean a children's clinic? A children's clinic is where you diagnose and treat children. A pediatric's a young doctor, usually Greek. And I don't understand why we have to make everything sound so complex. I was a patient of this man, John Barron, one of the fathers of hand surgery, when I picked up an electric bar fire at the age of 5. And characteristic, a lot of people, young people now won't know this, but these electric bar fires were very characteristic of the 1950s. And when you grabbed the element before it became red, you got an electric shock, you went into flexor spasm, and you got electrical burns to the flexor surface of your hand. And in those days, I was treated, because they didn't have free flaps, and tube pedicle flaps and things were very cumbersome, right at the beginning of flap technology. And I was treated with one of these, which is a very thin crane flap, they were called. And the idea was that they allowed revascularization of the surface, and then you took the hand out of the pocket after 3 weeks, and then you could skin graft it. And then instead of the lovely thermoplastic splints we have now, your hands were cast in these acrylic splints, which were then screwed together like a medieval torture to prevent contracture. And this picture of the hand there is very like the burn that I sustained. And they were treated by these compressing, horrible splints. So it was an enormously distressing time for a small child. It was all done to save essentially my little finger, which is one of the fingers you least need to worry about. The little and the index finger are really not fingers you need to mourn. And so when I was old enough to assert my preferences, I went to have my finger amputated, and it was the best thing I'd done, get rid of this contracted, scarred, unpleasant digit. So I learned a lot about that. About long before I was even at university, I learned a lot about what I believed were the shortfalls in care for children. And I suppose those beliefs and prejudices stuck with me. And I still see some over-enthusiastic, ill-directed care. And I suppose that forms the basis of why I'm giving you my personal view on some of the factors around consulting with children. So what I'm going to talk to, this is a list of things we're going to run through tonight. And it may look daunting, but actually it's all pretty straightforward. How does it differ from the adult situation? What are the things you need to think about? And I particularly want to embed in your minds the idea of transition ages, which ought to have red lights and flashing amber lights on them. Talk about the first consultation. A lot of you who don't treat children all the time may be unfamiliar with the really well-documented reactions to the birth of an abnormal child. And then I want to talk a little bit about how you make decisions for your child and how the surgeon and the family and the child come together to make those decisions, because I think that's less obvious than it seems. And if the only thing you get out of tonight is a higher degree of empathy for the difficulties parents face, then I think that's worth doing. I'd like to state the bleeding obvious, as Fawlty Towers would have it, and tell you a little bit about how you conduct the consultation, a tiny bit about indications, and I want to talk, just because it's controversial, about factitious disorders and then a bit of scent and consent. That sounds like a lot, but it'll be a gallop through, I promise you. How does it differ from adults, from consulting with adults? Well, obviously the patient may lack capacity. You can't reason with a very young child. They are vulnerable, and we all have a kind of idea of kids as being the quintessential human beings that need protection. The patient is growing, so when you're treating them surgically, you have to take into account growth and the influences of growth. And there are these stakeholders called the family, who may not just be the two parents. They may be siblings, aunts, uncles, extended family, and they may all have strong opinions. And it's worth finding out what those are quite early. Sometimes the person with parental responsibility is not the parent, it's the guardian or the custodian. And then there's a complicated concept, which is that the patient you're treating is actually not yet present, because what in many ways you're trying to do is optimize the future adult while not harming the current child. And that's a concept that you can roll around your tongue for a while, because it's quite an interesting one. The timing of surgery matters, and that's quite interesting in a healthcare system like the NHS, where particularly after COVID, the timing of interventions is not always within our gift. And then I want to say something a little bit about it's a moving target. But on the other hand, children are usually very fit and healthy. They heal well. But one of the things I like about them is, as one person said to me once, that there are no corners on a child. They don't deceive you easily. They don't set out to trick you. They don't try and trap you. I'm not saying all adults do, but certainly some do. Children are guileless. And people talk about plasticity and rehabilitation in children. It's a recurring theme. If you give a child in its hands something that is useful, it will use it. They make the best of whatever you give them. And there's just one caveat there, that they're never the same from one visit to the next, in my experience. And some of them are teenagers. And if you've got children who are or have been teenagers, you'll know that that's a minefield that only the intrepid enter. I think it's important to be aware of transition times, and those are when they're moving in their lives from one environment to the next. So particularly good examples are when they're starting at school or moving schools, or when they move into adolescence and puberty. I'll just say a little bit about that, actually. The adolescent is one of the most important transition zones, because not only are they changing their environment, their peer group, their self-examination and their esteem, but we know that adolescents have unstable body images for all sorts of reasons. And this is at a time that socialization and self-image is increasingly important. Notoriously anxious about appearance and functional concerns, including employability. Now, I'm not going to dwell on this because some people think I overemphasize it, but it's worth reminding yourself that among all the other attributes of the hand, it is a sexual organ. It plays a part in sex. It plays a part in holding hands, in touching, in stroking, caressing, let alone before you actually get to sex. And so it's unspoken, but absolutely certain, in my experience, that children coming up to the dawning of sexual experience and adolescence and puberty begin to get anxieties about, will anybody want me to touch them with my deformed hand? Will they want to touch my deformed hand? Will they want to be intimate with me? And the sexual pressures and angst on young people now are orders of magnitude greater, in my view, than when my generation was young. And the commercial pressures, particularly on young girls, but increasingly on young males, the media pressures, the portrayal of perfection, the sexualization of youth, make all of these things more pressing. And yet I don't know any hand clinic other than our own where we specifically raise this subject with adolescents and transitional ages and discuss it. So when you're seeing the child for the first time, you know you're treating the vicarious patient I spoke about. but you're also treating the child in front of you, but you're helping the family. You have to respect the family opinion. And if you don't agree with it, then the only way you can influence that opinion is by reason and fact. I think you need to be very, quite often a child will come to clinic repeatedly with only one parent. And that requires a lot of trust that the other parent is on board with what's being decided. If you have the faintest sniff of a divergence between the parental views, you really want to explore that, because if you go ahead with whatever plan of treatment when one of the parents is not on board or is even openly antagonistic, you set that family up to fail with its child and the care of its child. Not necessarily your fault, but if you can be alert to it, you can subvert it. Guilt. Every mother, I'm going to be didactic here, every mother with a child who has a birth abnormality of some sort feels guilty. They assume that it's their fault, and we'll come back to that. And interestingly, the father almost never does, although there's absolutely no reason why it shouldn't be his fault or the mother's. It's usually neither's fault, of course. When you have a complex problem in front of you, it's worth sitting back and taking a deep breath and saying, okay, well, I know there's going to be some rocky times ahead. There are multiple stages of surgery. As, for instance, if you have a child with Napert's hand, that you know you want to do some distal releases very quickly, and then you want to make decisions about other releases and graft cover and web spacers and so on. It's sensible to make a provisional plan with the family so that they're aware how long this is going to take. It's going to stretch over years, and it's going to intermesh with other treatments. And have a finite aim and finite terms, because it's very easy to blunder into the situation where you never know whether the surgical care is over. And one of the key things is that if you can make yourself into a team with the parents, and I know that sounds very corny, but it's true and it works, that's really valuable. For the ethics of what we're trying to do, you all know the 4 pillars of medical ethics: beneficence, non-maleficence, justice, and autonomy. And autonomy in a child is a rapidly evolving concept. It's changed enormously, both legally and behaviorally, in my lifetime. And we now know that with the puberty blocking, gender reassignment debates that go on all over the place, that the autonomy of the child has to be respected at the same time as protecting the child. And these are very conflicting, very difficult things to do. Usually they don't intrude into children's hand surgery, but just occasionally they do. At the first consultation, it's interesting to know who is present. I kind of feel, I suppose, in my career, I've felt that there's been a tendency for the surgeon, particularly the microsurgeon and the clever and gifted surgeon, gifted with their hands, that is, to think that they are the technician that will put right this broken piece of equipment. But actually, as we all know, what matters is the wetware between the ears. It's the brain and the mind. And I think it's really useful to learn at the first consultation, not just about the hand, you understand the child and the family. It's very helpful if both parents are there. Understand the expectations of the parents. And I say a couple of things that sound very arrogant, and I'm sorry if they do, they're not meant to. But the average IQ in Britain is 100 by definition. That's how we define 100. And below 100 is not very bright, actually. And yet half our patients will have an IQ below 100. And you're asking them to understand very difficult concepts that you understand perfectly and can be quite rapid and offhand about, and must be alarming and confusing to many of them. So it's always worth taking a deep breath and stepping back and saying, am I sure they understand what I'm saying? This big clever doctor telling them all these things and using words like symbrachydactyly and so on. It's just, you have to understand and explain. And I think that when you're treating any condition in medicine, you have to have a diagnosis and a prognosis. Explain the diagnosis and then the prognosis. And talk about that again briefly in a second. One of the things that's very therapeutic about the first consultation is in comes mum and dad with their child who's got an unusual hand condition, and it's 6 months old. and they're anxious. You'll see that their eyes are darting around. They're assessing everybody in the room, introduce everybody, but they're assessing them. What do they think? Are they shocked by the appearance of the hand? One of the great therapeutic maneuvers in that first consultation is to give them the reassurance that you're familiar with this condition. It's nothing new to you. You've seen a lot worse, or you've seen this condition before. They've been told by their GP and the local hospital that it's incredibly rare and they don't know the name for it, and so on. Reassurance of familiarity is very valuable. As I say, I like to provisional plan, and then never forget that before you end the consultation, you invite them to give you questions, because otherwise some of them may be too overawed or uncertain about that. Two things that I say in almost every first consultation is, this is not caused by anything you've done prior to or in pregnancy to the mother. And not infrequently, that provokes an outburst of tears, and much to the surprise of the husband often, because he hasn't realized that mum's been carrying around this burden of guilt that she was certain it was because she had a cocktail 6 weeks after becoming pregnant, or she was doing something, went trampolining or something. You know, always some in her mind going over and over, what have I done? What have I done? How have I caused this? And to be told it's nothing you've done is incredibly freeing. And the other thing is, I mean, it sounds incredibly pompous again, I'm sorry if it does, but I really believe that whether she or he has a happy and fulfilled life will not be determined by the hand. That will determine some abilities, but it won't determine whether she has a happy and fulfilled life. We could talk about what will determine that. So always you're asked these questions, is it my fault? Fathers are often astounded that mum thinks it's her fault because they haven't discussed it, and that's a kind of red flag. Mother may be ashamed. In my experience, there's a sexual dichotomy between mother and father. The mother is concerned about, will she suffer? Will she have pain? How can I protect her? And the father wants to know, what's the bottom line, and we get on and treat it. And I hate to be quite so brutal in that distinction, but it has been a generalism that's been often true. How do I tell others? How do I protect him? The mother will jump all of these fences years in advance, and often at the first consultation. How can I protect him from bullying? He's 4 months old. How can I protect him from bullying? Why can't he decide the treatment? Will his fingers grow back? And right at the beginning of my career in Leeds, 30-something years ago, 33 years ago, I appointed a psychologist for our clinic. And it was precisely because, although I have opinions and some experience and value that I can add to that conversation, a proper consultant clinical psychologist has the time to spend an hour with the patient, the expertise. They have an extended professional sphere, so it's not just psychology, but counseling, advising, and assessing. And they can link in with other services, including therapy and social services and CAMS. So if you're treating large volumes of children in a children's clinic, I can't think of a good reason not to have a clinical psychologist as part of your team, and preferably in the clinic with you. Now, let's talk a little bit about bereavement, which is a very common, it's a very common analogy with the loss of the anticipated perfect child. There is no such thing as a perfect baby. Advertising bombards us with images of perfection in all things. And if you sit in front of the television in the evening and you look at the advertisements, every wife is perfect, every dog is perfect, every child is perfect, every home is perfect. No one portrays life as it really is in advertising. They portray how either the company or others feel you should be, and no one sells things on the basis of imperfection. So just as with the sexualization of young people and the expectation of perfection, so parents are bombarded with adverts where they have perfect children. You never see a child in a Pampers advert with a cleft lip, or, you know, it just doesn't happen. It's a shame, and it gives the lie to how meaningless it is. So mothers particularly who mourn the loss of the expected normal child have the constant reminder every day of that bereavement. When a relative dies, by and large in this country, we either bury or cremate them. What we don't do is prop them up varnished in the corner. So when you mourn the loss of your expected perfect child, that child is there every morning. It's constantly reminding you. It's also exacerbated by the constant attention of others, and that horrible situation in the supermarket where they lean over the buggy and say, "Oh, isn't it? Oh," and the mothers dread that. And sometimes it's exacerbated by over-enthusiastic repeated medicalization by frequent attendance, and we can prevent that. Sometimes the birth of an abnormal child may be met with relief. Oh, he's not got a thumb. Is that all? Thank heavens. I mean, it could have been so much worse. And that's a true reaction for some parents. And I think actually a pretty healthy one in my opinion. But the reactions of bereavement are those that you see in parents of children, or the anticipated loss of the perfect child. And they include, in no particular order and no particular prominence, the Kubler-Ross stages of grief, which I know are controversial these days, but they're kind of a good format of guilt, anger, shame, denial, and acceptance. Denial's a particularly interesting one. And it's important to know that just as in the bereavement process, any one of these can become maladaptive or abnormal, usually on the background of other parental problems. And so in the clinic, you or your psychologist or your clinic nurse or your therapist, all of whom have input, incidentally, in our clinic to monitoring and assessing and discussing the child and the family, all of them have useful insights that may be gained in the absence of the surgeon or the absence of the psychologist, and they all contribute to the picture. But you want to spot these signposts if you can, because although it is rare to have a seriously maladapted response, I've had at least one child be killed by its mother after a maternal depression and maladaptive response of denial. And all the signs, or many of these signs, were there. So in that child's mother, maternal depression and isolation was evident. Denial, she believed the child would grow more fingers. She hid it. The child's hand was never exposed, and I had to specifically ask her to take the glove or the mitten or whatever off. She might request unnecessary surgery. And sometimes you spot that the father or the mother may be discordant, and particularly the father may be impatient and not understanding the emotional burden of the mother. And then the thing that's often missed is when they stop attending, when they need to attend. So when they have something that clearly is serious and they should be coming and discussing a plan and so on, and suddenly they don't come. So when you look at your DNAs, you do not attend, you have to think, why have they not attended, and is that appropriate, and can we reach out? And in our clinic, the nursing staff do that, and they're on board with this whole scenario. Now let's talk a little bit about decision making. Those of you who've had children or have children, I say have had children because my children are grown up now. And let me tell you, those of you whose children are just going through the difficult stage of adolescence, it doesn't get any better. They are complicated throughout their lives. I suspect they're complicated when they're 50, you know. But decision making for them is very difficult because you're making decision on the background of very difficult emotions. There was an American surgeon when I started in practice who used to come over, dreadful man, and he used to consult in hotel rooms, and he'd take parents and their babies within the first 3 months of life and make exuberant promises to them about care and fly them over the States for care. Well, they're very vulnerable in the first 6 months of a child's life. The parents are very vulnerable. The emotions are surging up and down between relief and depression and guilt and shame. So it's a very complex task on that background. And the suggested surgery may further raise the angst. It's always daunting to make a decision for somebody else, especially somebody you don't really know yet, but who you know is going to be with you all their life, all your life. Always daunting to make a decision for a child. And then they're having to balance the functional, the cosmetic, and the psychosocial considerations. We've spoken a little bit about them, but I just remind you that the hands and the face are the only bits of the body on show all the time, at least in our country. And they play an important part in every part of our lives, particularly communication and relationships and caring and sex and activity and labor and everything. So we have functional, but we also have cosmetic and psychosocial concerns. And threading the line between those is a daunting task for a highly intelligent parent. And it must be a very daunting task for a parent who's not particularly well educated or not familiar with all the vicissitudes of medicine. So what are we trying to do? I like to try and maximize. I like to think that one of the things we're doing is maximizing the child's future ability while minimizing damage to the child and family. It's worth remembering you don't have authority over the child. It's very easy to think of them as your children in clinic. So you have to work closely with the people who do, and that's the parents. And of course, the parents take responsibility for consent. We'll consider law and consent at the end. But very soon we start looking for the child to at least assent to care. And very rarely in hand surgery, but sometimes and more commonly in plastic surgery, which I also undertake, we're looking at capacity in the borderline teenager. The commonest question, parents who are struggling with a decision, can we wait until she can make her own decision? Say you're recommending a toe transfer in a child with symbrachydactyly or transverse arrest or a polycization. Can we wait? Of course you can wait, but it's usually inadvisable. When would she be able to make that decision? When does a child become competent to make a complicated decision like that if the parents can't make it at their age? And so it's worth gently reminding parents that it's their duty to make decisions for children and our duty to inform and support them, not to tell them what to do, but to tell them why we think this is a good way of going about it. So that means reviewing and explaining. And if you've got a parent who won't make a decision and continually says, we want to wait until she can, and I've had this with duplicate thumbs, with polycizations, with symbrachydactyly, with syndactylies, it's best to keep reviewing, best to keep explaining, meet other parents and discuss the anxieties. Sometimes, to your surprise, the parents may know more than you about the condition. And I certainly had the situation where a young girl came to me with ring long finger syndactyly with a length, there was length discrepancy and the long finger was beginning to get a contracture. And I said, I think we should separate this. And the parents said, we don't really want to at the moment. And I pushed and pushed, and I was a bit bullish about it. And then finally, father held his hands up, and he had ring long finger syndactyly. It had never been corrected, and asserted that it had never held him back. That's kind of an embarrassing situation, and that makes the whole discussion go back to basics again. I wanted to have surgery. My wife doesn't agree. Whoa, that's a problem. Parental concurrence is essential. And particularly in hand surgery, where it is almost always not life-saving. It's about quality and the future. It's worth remembering that. You're not heart surgeons, you're hand surgeons. Only very rarely would I accept it. In fact, I can't think of a circumstance in which I'd accept divided opinion. I say rarely because nothing's ever absolute. Mothers tend toward protection, fathers solve the problem. A group meeting with both parents and clinical psychologists and you may be very useful, because what you don't want to do is go ahead and have one of them sulk, and then something goes wrong, and then the child is weaponized and the surgery is weaponized, and you've moved the whole family backwards, every one of them, and not one of them forward. And then some parents say to me, but when we do surgery, if it doesn't work out well, or she doesn't have a good new thumb, or the fingers don't work, or the syndactyly's got horrible scarring, she'll ask us why we agreed to it. And the answer is simple. You made the best decision in what you saw at the time as her best interests at the time the decision was needed. It was your duty. It is your duty. And no child can second guess you in the future about that. especially if it's explained clearly that that's what you have to do. It's a duty to make that decision. You can defer it, but you're abrogating your responsibility, in my view. And you can explain that, explain it again, explain it again. You can't force it, but I think it's an important thing. I'll just have a little diversion here, because I have so many examples in my career of the strategies that parents and children have for dealing with differences in appearance. And I just want to run some of them past you. Teasing is very important. And if you see children a lot, really sit down and read some textbooks on teasing, because it's interesting. It's a form of bullying, of course, and it's interesting how subtle it can be, and it can happen within the family. And sometimes that deformity in the hand can be weaponized to settle scores as the child gets older. So, and the teasing just has to be perceived. It doesn't have to be real, actually. So if the child feels teased, they are teased. I know we're getting into deep water here. But this is an important conclusion in 2003 paper that I think was worth reading. Through real or perceived experience of teasing and harassment, children may come to the conclusion they're deficient in attributes that classmates perceive as important and valuable. And that means, boom, boom, low self-esteem. Even if the frequency of teasing tends to decrease with age, studies have found that the negative effects of having been victimized persist into adulthood. What happens as a preteen child marks you for the rest of your life. And so that's something that our psychologists are particularly hot on and liaise with schools about, and liaise with school social care. Peer harassment during childhood may still affect adolescent satisfaction, even if they're no longer being teased. So it's an important thing to divine, to ascertain, to establish with the family if it's happening. And we always ask about it, not just at the first interview, because it's not happening then usually, but particularly at transition times that I've mentioned. We can support the child through teasing. We can outreach to the school. We can advise the parents on strategies. One of the great things that clinical psychologists come with is a great bundle of things called strategies. Here's a strategy for you to deal with how they're teasing you at the age of 8. Here's a strategy at the age of 12. Here's a strategy for the school. Here's a strategy for mum. They're kind of off the shelf, but adjusted for the circumstances. And I think they're very valuable. And again, I say, get yourself a psychologist. Coping mechanisms. I've seen so many children growing into adults with all sorts of coping mechanisms, whether it is writing about their hand differences, whether it is supporting organizations like REACH, whether it is defiant achievement in sport. Defiant achievement in sport's an interesting one, because it's what underpins the whole idea of the Paralympics, and it's greatly to be admired and encouraged in most circumstances, but it can become a maladaptive response. And the way that happens is that the parents push the child, and sometimes the child will be, for instance, swimming really well with an obstetric brachial palsy, and then at 14, 15, they'll come to me and say, I've got a lot of pain, I've got a lot of pain. The pain doesn't fit the examination, and it doesn't appear to be correct. And you start to wonder, and it's the child's way of stepping back from the expectations the parents have of its defiant achievement. And I've had quite a lot of parents come to me and say, could I categorize their child as more disabled, so that in the banding, so that they can compete more effectively. So it's important to support it, but recognize when it's starting to go wrong. I'm very keen on resilience in children. And one of the things that I've learned from many lives of other people is that adversity in childhood can be very enabling. So if you have the right circumstance, and you face adversity in childhood, and you come through that adversity with the correct support, and one of the adverse things can be an abnormal hand, then you can become a very resilient child. And resilient children have good emotional intelligence, they have better understanding, and this comes through successfully dealing with adversity. And we know from a lot of the work on resilience in after childhood that it comes from support from family groups, from faith organizations, from organizations like the Scouts or swimming clubs or whatever. But support and iteration and encouragement and back to support can turn a child who's had the misfortune to be born with an abnormal hand into a very gifted child as a result of that abnormality. It can make lemonade from lemons. Now let's talk a little, and I recommend the resilience advantage. Now let's talk a bit about practicalities. In the clinic, the same rules apply to your interaction with children as they would to any other person. Because they're children doesn't mean that, you have to treat them and ignore them like an animal. In fact, I think you should probably be introducing yourself to animals. Anybody who knows dogs will introduce themselves to a new dog. So apologize to the child if you're late. I mean, not if it's 6 months old, please, but you know what I mean. Address the child as age appropriate. Don't do this little oochie coochie voice and things. The child immediately smells a rat when a great hulking adult starts doing that. Address the child as age appropriate, if appropriate. Introduce everybody. Controversial these days, make physical contact. I think if you're in the presence of the parents, it's quite all right to reach out and encourage the child or touch it, whatever. There's something very reassuring about that being done in the correct way. Certainly make eye contact, say something nice and settle them in. And I put this for the medical students, and I don't think any of you need telling that all medical care starts with a history, an examination. Don't go straight into the hand, get the history. And the history, not just of the hand, but the family and how they feel about it and how it's affected them so far. Then the examination, investigations, x-rays are usually helpful. Diagnosis. And only when you've got a diagnosis can you start to talk about the natural history. Now, the natural history may be obvious in some hand conditions, but it may not be in others. And so only when you know the natural history can you have a prognosis and a plan. That's for all of medicine, but it's no different for hand surgery. Sometimes kids, infuriatingly, particularly when your clinic's running late, won't let you examine them. Well, no surprise there. You're a great big hulking brute of an adult they've never met before in a horrible environment which smells of fear. And then they're bloody right, they shouldn't let you touch them. So don't force the issue. Don't hurry, they can sense and use your impatience against you. I often examine another child, or if they brought a sibling into the room with the family, examine the sibling, examine another limb, considering going out and examining the waiting area where there are lots of other children. I like clinics to run a little bit late and have a big, busy waiting room. Never mind COVID. I think it's great because families see other families. They know they're not alone. Their children know they're not alone. They're not special. They're not horrid. They're not uniquely bad in some way. Consider a second visit. Now, it's difficult if they've come to Leeds from Exeter. It's very difficult, but sometimes you have no choice. Be very careful about forcing it, even if you reach the end of your tether, because it's very easy to put that child against you. The most successful strategy in my clinic is that the physiotherapist who works with me and the psychologist, both female, much less threatening than males, hulking males like me, let somebody else examine the child while you watch. You don't need to do it yourself. And bribery if all else fails. The psychologist will talk, so often we'll make a separate appointment with a psychologist, and they'll talk about all these things, the guilt again, how to talk to the child, how to deal with unwanted interest and bullying, and will the child cope, and all the fences that mum jumps. I want to say a little bit about contraindications surgery. Vulnerable parents, they're all vulnerable, actually. They're especially vulnerable in the first 6 months. You can get them to agree to almost anything if you want to. It's a bit unethical, don't do it. you can tell them, take a break from making a decision, have a rest, enjoy your child, come back in 6 months, a year. It really doesn't have to be pushed. Be careful of family opposition. Great Aunt Mabel thinks this is a bad idea. Well, why don't you bring Great Aunt Mabel along to clinic next time and we can examine her rather quaint beliefs about this, perhaps. Other illnesses, of course, if they've got cardiac conditions, epidermolysis bullosa is one, unrealistic goals. Graham Lister said to me, beware the adult that comes with a congenital condition. And I found that to be absolutely true all my life. If they come at the age of 28 with a condition that should have been treated at 2, you have to understand why. The timing of surgery, let's talk a little bit about that. I've already said if what you add to a child's hand is useful, I'll use it. There are 4 broad indications for surgery: prevention, function, appearance, and pain. And I want to say that pain is very uncommon. It's a very uncommon indication for surgery in a child's hand, even after nerve injury, and even in the most complex time of transition. So be alert to other influences, like the child that wants to withdraw from the Paralympic swimming program, as I said before. Some things are urgent. Most things can be done. The prevention and preparation of surgery, like the correction of the wrist in radial dysplasia, they have to be done relatively promptly, and they may prepare just for further surgery or for therapy. So they have some mandate in timing as well. But most things can be delayed between 6 months and 4 years. Anything complex, we try to get done before school, just because taking time out of school is difficult. But the reality in the NHS is that we don't have that kind of luxury of being able to schedule every surgical appointment, certainly not in Leeds. I don't know what it's like in the rest of the country. And later, marginal cosmetic or functional indications, you know, they can wait for the child to make a decision. Let them come back to you if they don't like what they've got, because they'll be motivated. There are some times to avoid major surgery. I've said the first 6 months. 6 to 10 years, the child has autonomy then. There's no arguing with that. If you've not known a 6-year-old who doesn't want surgery, you'll know they have autonomy. And they're resistant, but they're difficult to reason with. And so between 6 and 10 years, those are the resistant years. And this child blew his hand off making a bomb at his father's funeral. I think it's pretty, even I could recognize there are some unresolved issues there. I'm going to say, because one of the audience tonight asked me if I'd speak briefly about factitious disorders, because I have quite a lot of experience of that in adults, because particularly in plastic surgery and hand surgery, nerve surgery especially, we see a lot of them. We don't talk now so much about Munchausen's by proxy. We talk about factitious disorder imposed on another. It's just a politically correct way of saying the same thing. Richard Asher, psychiatrist at the Central Middlesex, first described Munchausen's syndrome. Like the famous Baron von Munchausen, the persons affected have always traveled widely, and their stories, like those attributed to him, are both dramatic and untruthful. Roy Meadow, who is professor of pediatrics here in Leeds when I came, and with whom I worked quite a lot, described this syndrome of Munchausen syndrome by proxy. And some people find it very difficult to believe that a parent would fabricate an illness and get healthcare seeking disorders in their child. But we know absolutely incontrovertibly it exists. And I've had quite a few cases over the years. Often they're never completely resolved and remain disputed, but there are things that all surgeons treating children should be aware of. There should be discrepancy between, this is a very good paper from Chris Bass and Daniel Glaser in Oxford, by the way, and it's worth reading, in The Lancet in 2014. It's a very clear exposition of this. So the reported symptoms may only be observed in the presence of the parent or carer. They don't respond properly to treatment. New symptoms are constantly appearing. The history may be biologically unlikely. And despite reaching a definitive clinical opinion, they continue to seek opinions and care from other people. And relatives may express concern, or other professionals not willing to tackle this themselves. And I can understand the great difficulty of tackling Munchausen by proxy. It really can dominate your professional life with just one patient, but they may hint darkly at it, and it's worth taking that seriously. If you don't want to tackle it, I think you have to get onto a psychologist and a clinician who will, because otherwise they just bounce from professional to professional. But the latest case I had was a mother of a child with very mild arthrokyphosis who was insisting on surgery. Not any specific surgery, she was just insisting on surgery repeatedly and refusing to leave the clinic at times until it was agreed. And that became a very, very complex case involving GPs and social workers and evidence of harm in another child. So these are worth looking for and being alert to. Little bit, very briefly, about permission to operate. Valid consent for adults involves the doctor disclosing information to a competent patient, the patient understanding the information, its implication, and making a voluntary, uncoerced decision. And the parallel is true for children. I just want to say, those not familiar with this, that parental responsibility is identified. It is possible to identify people who have parental responsibility. They are usually parents, but not always. And so under 16, we all know about Gillick competence, but there are some surprising findings in the under 16-year-olds. 16, 17-year-olds are presumed to have capacity. Children under 16 may have capacity. The precise criteria for judging capacity are complex, and they may not be universally agreed. They say, and this is from the BMA handbook, the unlikely courts would consider children aged 13 or under to be competent in most situations, but it is entirely context sensitive. And what we're looking for in young children is assent. They may not be legally allowed to give consent, but assent to the child is desirable. What is difficult is if a young person refuses treatment. Now, usually in hand surgery, that is not a problem because their lives are not threatened. But if you believe that by not having treatment, for instance, for a nerve injury or a fracture, that they may come to significant harm that can be prevented, then you have a responsibility to either enlist the consent of the parents and the assent or consent if the child is competent, or if you believe the child is not making a competent decision, then you have responsibility to protect that child. And so you need to take advice from both child protection and your trust's legal team. And remember, whatever you're doing with these children, you may be treating them more than once. There's one line I want to pick out in this slide. Parental responsibility exists for the benefit of the child, not the parents. Parental responsibility does not confer on parents an absolute right to make decisions on behalf of the child. Overriding that can be done and can be necessary. And what I found in this study was interesting is that generally children of 11 years and above were decision competent, while children of 10 years and below were not. So there was a cutoff there, and that's a general principle. There was a spread either side. It's important that young people give their assent if they're not of an age. So you can't drag a child kicking and screaming into the anaesthetic room. And it's not infrequent that despite all appearances to the contrary, the child in the anaesthetic room is distressed and resistant, and then I do not go ahead with their treatment. I don't believe in this, wrestling them to the bed and gassing them into submission. You have to remember that the biggest influence on assent is not just fear of pain or inability to conceptualize the benefits or cultural norms, it's past aversive experience. And if you lose that trust once in a bad way with a child, you've lost it forever. So in practice, I never persuade or coerce a child when I'm being resisted. I always detail the options, including no treatment. In terms of the parents, I acknowledge the range of cultural opinions, and in a multicultural society, particularly we live in one here in Leeds, most of the UK, is acknowledge the range of cultural opinions. And if you have a big demographic of different cultures, it's only right that you learn what those cultural opinions that are embedded are and why they are and how you can address them and discuss them and how you can comply with them. Involve a wider circle in the discussion, delay consent, and accept only the opinion of those with parental responsibility in the end. And in the end, your job is to protect the child, whether that is to go to the courts and ask for care, highly unlikely in hand surgery, but it does happen, or whether it is to protect the child against being distressed. Below 4 years, they'll kind of do what you tell them. They're ductile and they can be hoodwinked and supported and bribed. At about 6 years, they begin to be self-aware and also autonomous, but without capacity. And that's why they're the resistance years, the 6 to 16. And when that mother right at the beginning was saying, why can't she make her own decisions? When do you think that would be, Mum? When was she really able to make that decision? Because it may be a lot later. It won't be at 6 or 7 or 8 or 9. It'll be in her teens. So managing vicarious patients requires specialized skills and knowledge, and at least a fair amount of reflection and understanding of the difference between children and adults. I can't imagine treating children without the help of clinical psychology, particularly in any kind of complex care. And you can't treat the child apart from the family, and they're not a technical exercise. What matters is what's between their ears, not what hangs off the end of their arm in the end. That's my opinion anyway. And I have one slide that I always love to show, which is Harvey Cushing, who said, I should like to see the day when somebody would be appointed surgeon somewhere who had no hands, but the operative part is the least part of the work. And I really believe that to be true. Thank you very much.